You walk into a room and your patient has nausea and vomiting nonstop. Her sodium level is 128, chloride 92, and her bicarb level is 34. Her mucous membranes are dry and she's clearly volume depleted. Before you grab fluids, stop. If you choose the wrong one, it can worsen acidosis, overload the kidneys, and tank the MAP. So let's match fluids to physiology. Which fluid restores volume, replaces chloride, and raises sodium appropriately? Normal saline. It has 154 milliequivalents of chloride and sodium. Why does it work? Because restoring the volume drops the ADH. This will allow your patient to excrete free water and your sodium level will rise. And chloride also corrects metabolic alkalosis. But normal saline is not used for patients with SIADH because it can make the sodium worse. Your second patient is septic. MAP is 55. His lactate is 6 and his chloride is 112 milliequivalents per liter. And his potassium is 3.2. Which fluid supports perfusion without worsening acidosis? Lactated Ringer's has a sodium content of 130, chloride of 109, potassium of 4, calcium of 3, and a lactate of 28 milliequivalents per liter. This balanced chlorides avoids hyperchloremic acidosis. Do you give this fluid to patient with a lactic acidosis? Absolutely. The lactate is a buffer, not lactic acidosis. The third patient has liver failure with a lactic acid level of 12. His ammonia level is 89 and his chloride level is 108. Poor lactate clearance because of his liver. Which fluid avoids lactate metabolism entirely? Plasmolyte. It's great for liver dysfunction. Sodium level of 140, chloride of 98, potassium level of 5, magnesium level of 3. You want to avoid plasmolyte in patients with renal failure. Why? Because of the magnesium and the potassium. Your fourth patient is hypernatremic with a sodium level of 158 and chloride of 118 milliequivalents per liter. Her osmolarity is high and her mucous membranes are dry. Which fluid gives gentle free water replacement? Half normal saline. It has a sodium level of 77 and a chloride level of 77 milliequivalents per liter. This hypotonic fluid will be good to lower the sodium gradually. Definitely want to avoid this fluid in patients with hyponatremic encephalopathy, post-op patients, or anyone at risk for hyponatremia. Your final patient has a sodium level of 165. His osmolality is high and his glucose is 110. Which fluid becomes free water once the dextrose is metabolized? D5W. It's great for hypernatremia. This is not a resuscitation fluid. And you can't use this fluid in patients at risk for cerebral edema because this fluid is hypotonic. And one more important thing. Why would you never hang free water by itself? It will hemolyze red blood cells. D5W is the only safe way to give free water IV. The dextrose makes it isotonic in the bag. To recap, normal saline can be used in patients who are hypovolemic, hyponatremic, and who have chloride loss. Lactated Ringer's can be used in shock, sepsis, and acidosis, and in patients with liver dysfunction and metabolic acidosis. Half normal saline can be used in patients who are hypernatremic needing gentle sodium correction. And D5W is pure free water once metabolized. Remember, IV fluids are drugs. Match the fluids to the physiology.